All right. Yeah, so I'm going to give three examples really of how citizen science is working. And the first probably known to you is the ZOE COVID study, which was originally called the COVID Symptom Study app, which was launched at the height of the pandemic in March 2020 on the first day of lockdown. And this app was built by engineers at the small startup company ZOE, which was doing nutrition research, and it was basically built in about 5.5 days. And amazingly, the timing was perfect, and about 1 million people downloaded it in the first 24 hours. And it went on to have about 4.9 million people who had used it and given us their data across 3 countries. And it averaged about 850,000 daily contributions. So this app, which really depended on altruism of people to give their results, how they were feeling, their tests, where they were living, all this kind of stuff was amazingly successful. And we had no clue whether it was going to work or not, whether anyone would download it at all, because we were unhelped by the NHS, the government, anyone else, and it was purely driven by social media. But it certainly struck the right chord, because people felt that somebody was interested in what was going on. And I think this is the first insight into how do you make these things work. It's by giving people something that they want, and in return they'll give you something back. And this is this very powerful message. And people are still saying, yes, telling me now that in those first few months, when they were at home, frightened, not knowing what was going on, they felt a great security about doing something, logging every day, and getting feedback about their local area and what was happening. They felt very much part of a strong community. And this is just a small list of the achievements of this app with, these up to 4 million people helped give all this data that was in real time fed back to scientists working at King's College and also at ZOE. And we together managed to change the world's perception of COVID, found out that loss of smell was a crucial symptom in those early variants, highlighted things like skin rash, differences in kids, pointed out the scale of the problem long COVID. We could detect hotspots, early detection of severe cases, early vaccines, of course, people were logging them. And as the symptoms developed, we could find the differences between Delta and Omicron, B1 and B5, more recently, colds and COVID. And this led to over 40 scientific papers and 100,000 media articles. So by any stretch of the imagination, I think we can see that was a success. And ZOE have still, they're still using that cohort now to keep tracking COVID and colds, but as we'll discuss, are trying to transition it into a wider health study app that might also do big, large-scale interventions. Okay, so I'm going to switch tack now and go to my other set of interest, which was nutrition, which came out of personal problems that I had about 12 years ago when I got sick, and I wanted to look after my own health, and looked what the government websites were telling us about nutrition advice and health, etc. And it was all about counting calories, avoiding high-fat foods, starchy foods, never skipping meals, all this kind of stuff, and eat little and often, and one diet fits everybody. And of course, I now believe this is complete nonsense, and it's not evidence-based at all, and yet it's rammed down our throats and on all the NHS websites. And nutrition is a good example of where a lot of the data has been based on studies of 7 people and never been generalizable to older people or anyone with who isn't a sort of student. And even the world's leading experts don't agree on many of these issues. They agree that things like biscuits, KFC, white rice are bad for you, coffee, berries and olive oil are good for you, but all these things in the middle, diet drinks, orange juice, low-fat foods, very unclear. I found myself that I'd been following a good doctor's diet, but well, eating muesli and orange juice and tuna sandwiches at the canteen, and I'd been slowly putting on weight over this time. And I found it was all related to things that I hadn't thought about, such as sugar peaks, which brought us to realize that actually nutrition is much more complicated than we've thought. It's not about macronutrients, it's not about calories, it's about the complex interaction of tens of thousands of chemicals in the food, in our gut, and in our blood. And a lot of it revolves around the microbiome, which again, even more complicated and contains 200 or 300 times more genes than we have in our own body, basically producing a natural pharmacy producing things. So the whole picture is extremely complicated and changing very fast with the science. And it was this background that a couple of entrepreneurs came to listen to one of my talks and said, who'd come from the internet, the world of internet advertising, where those annoying adverts follow you around for the next year once you've clicked on something, whether it's handbags, shoes, or travel brochures. And they said they wanted to do something on health. And this was timely because at the same time, the technology had evolved to look at AI. We had big computing. We had suddenly glucose monitors that could track what was happening in real time. You had blood spots that people could do things at home on, reliably measure your blood fat levels without having to go to hospital. You had apps that could record your food and your mood and get real-time updates. And the technology was also able to look at your gut microbiome with genetic sequencing. So all this came together at the perfect time to allow us to suddenly take something like nutrition, which has been pretty much in the Stone Age, dealing with 20 or so people at 20 versus 20 studies to give us all advice about food into a much larger scale. And that's really what these PREDICT studies did, where we took initially 1,000 people, including twins, gave them all identical meals, and then looked what happened to their bloods every hour and used that as a basis for an algorithm to do home testing on bigger groups. And that's the group you can see on the right, the PREDICT-3 study that now has about 45,000 people who have done exactly the same test and exactly the same, they've had the same breakfast at the same time and have the same measures on it, as well as having 45,000 results of their microbiome. So the scale is enormous compared to what we had before. And the design of this, the reason I'm mentioning it in this context, is that individuals are able to sign up for themselves. They're now paying for this. The initial ones were part of the trial, but they're now paying for it. But they're consenting to a community study at the same time. So they're consenting for their data to be shared. And this means that they get the benefit of seeing how their data fits in with everyone else's, and they get the shared benefit of the increasing size of the data set for the algorithms. So we give more personalized feedback to them. And so they're actually signing a research agreement in that scenario. And it turns out that we're all very unique in our responses, and we have very different responses to food, for example, even identical twins, which is quite unusual because we all have very different microbiomes. And just an example, things like what you eat can affect your mood, give you big sugar spikes and sugar dips. And it turns out that only by measuring thousands of people's results did we find that people who have a dip in their sugar levels 3 hours after eating end up feeling more tired, more hungry, and overeating by 300 calories in the next 24 hours. So only by collecting this data do you understand some of these things that can affect many people's lives. If they know they are a sugar dipper, they can then avoid that carby breakfast and would actually over time avoid overeating. So these things have culminated in this ZOE program, which is based on those initial tests, but on a home kit basis, that people do these home tests and then return them and then get their results and then have a nutritionist digitally working with them to do that. And these are just my results, which can't see very clearly, but they were pretty terrible, apart from the fact that I actually had a parasite, which previously we'd have got rid of, but it turns out it's a healthy parasite, but it eats my fat for me and digests it, so it doesn't go into my bloodstream. And we would never have learned that this parasite isn't actually helpful until we've done this in 30,000 people. And just want to leave you with the other example is the COVID study has transformed into the ZOE Health Study. And as well as just collecting longitudinal information about symptoms every day, how people are feeling, we've just about to start the first of a number of intervention studies. So we're asking people to, who on this free app, you download the free app, the ZOE Health Study app, and then you can participate if you want to in lifestyle changes. So this one we're launching on Monday. It's called the Big If study. You do intermittent fasting, which we mean time restricted eating. And we're asking you to eat exactly the same, but within a 10-hour eating window. So you might want to move all your meals forward or back and see how you get on. And we want everyone to do this for 3 to 12 weeks. And this is, we don't know how successful this is going to be. We're hoping to get over 100,000, hopefully up to 1 million people doing this. And I think this could really start to revolutionize the way we start to do trials. And the idea is this: if this works, we then get other people to suggest other trials or exercise or sleep or other things they can do, or even build up sub-communities to do these same studies. The app, of course, is just the tool. People log where they want to participate, their timings, they will log their mood, their energy levels, their exercise, their sleep, and this can be done daily with prompts. So we think this is a fantastic tool for the future, and that hopefully it's going to have as much success as the COVID studies did, which I think really changed the way we're doing epidemiology research forever. So I'll finish there, just say large-scale community studies are the future. I think feedback and two-way flow of information is crucial. The old studies of biobank, etc., lacked any real feedback or interest to the participants. And we've learned that it has to be rapid. They have to be the first people to know the answer, not waiting a year for the papers. And it's this two-way benefit. Participants need to benefit, and they also have to also be altruistic. And together, it can really work. And these are my contact details if anyone wants to know any more. So with that, I will stop sharing, and hopefully that's worked and we can get some questions. Well, it depends which study we're talking about, but I mean, day to day, our twin studies, we have an advisory group that we run past every trial on, and we're starting to develop that in the health studies app. So we have we do surveys before we launch anything of say 1,000 people to say how interested would you be in this study, what percentage wanted to do it. So that before we launched the intermittent fasting study, we did this in our core group of 1,000, and I think 80% said they would be interested in participating. So yeah, we generally try and involve them. We haven't quite worked out whether we should ask everybody first or just a subsample. We're sort of working on that. Okay, so I think the first part of the question regards maybe the commercial app, the ZOE app, nutrition app. How generalizable are the results from that? So that's these are the 45,000 people that have done this so far in the US and the UK. And clearly they're people who pay for a healthcare product are not going to be generalizable to the population. But I think they are the people who are expressing a need. And so you are going to have a range of obese, skinny, healthy, unhealthy individuals for that. The hope is that basically as the numbers get extremely large, you can at least get subsets in those groups. We'll never get to deprived groups until we start giving out, say, free kits. And we are in the UK starting to work with general practices where they might be able to give to some their diabetic or pre-diabetic patients are particularly at risk. So we're trying to get some information in that way. But we accept that all epidemiology cohorts are not generalizable because they're volunteers. And that, there's not much we can do about that. For the ZOE Health Study, again, we are not generalizable. People who tend to volunteer for these things are not the ethnic minorities, for example. We have a majority of females who are more altruistic than males, usual sort of problems. But by huge size, I hope we can then get enough subgroups that we can at least extrapolate to those groups in society. It's difficult to do that in the community on the free basis because we're trying to keep the community studies free. And at the moment, someone's got to pay for it. The sort of concept is it's under individuals' control. So it's doing things that are easily, they can just do on an app, or it's not very hard to do. So spending several £100s on microbiome testing might be difficult, but we could do things like transit time, where we've developed a free test where you eat a blue muffin and you look at your transit time, which does correlate with gut health. So that's possible, but it's more things that you can record on an app. So things like mood, sleep, energy, appetite, weight. We've got 80,000 people measuring their own blood pressure now regularly, which I think is great. Yeah, I mean, the challenge with the COVID study, if we focus on that one, was we had to get things done really fast. Obviously, we developed the app in 5 days, and we did get help from the King's College Ethics Committee to approve it rapidly. And it was really on the understanding that we kept control of the data. And so to get it approved rapidly, the only real way was to the data was held between King's and ZOE and wasn't disseminated widely. That was the fast, rapid way to get it done. And we just had to show that we had the safety controls in there. As we went forward to the health studies, we had to reconsent all the individuals because the initial consent was it had only to be dealing with COVID, and we couldn't go outside COVID. And so I think we had over 1 million people reconsented to what we call the wider health studies, which meant that we could collect more data, but we still have problems about its dissemination widely. That seems to be the problem. We haven't quite solved for that yet. But the difficulty is doing this at speed. You just try to get things going, because the difference in this and a normal study is it's just happening at 100 times the speed. And therefore, you do what you can, and then you deal with that problem next. But that's essentially it. I mean, I think it was important to get some ethics, although, in fact, it's interesting. The company itself doesn't need ethics to do this. It's only the university does, and if they want to publish the results. So it's slightly ironic that the ethics is tougher for a university group to set up an app than it is for a company. Well, it's completely voluntary, and we selected a time window that wasn't too strict anyway. So many people do this normally, eat in a 10-hour eating window. And yeah, we certainly are aware that people with eating disorders could, overdo it, if you like, but it's a short-term study. We don't believe there's any health implications of it. We do have a warning in there that if you have an eating disorder, you should consult your doctor before taking part. And we got ethical approval on that basis. But you can't, for things that are out there that everyone are doing, it makes sense to be as inclusive as possible, so people can see whether it is harmful or not in a pragmatic way. So if you're too protective, you never find out the truth. Well, for the nutrition app, we've got observational studies of people who've completed 3 months to show they do lose weight, they are less hungry and have more energy. We're doing an RCT to do this properly, which we will have the results of in the new year. So the main thing is that once you reduce sugar spikes and fat spikes, big change is energy level, which is actually was a surprise to us. But yeah, the RCT will tell us exactly how it compares to standard nutritional advice, and whether it lasts 6 months or more.